We are live now, doctor.
Okay. So, good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today evening. It gives me immense pleasure to welcome you all to the third masterclass of the online postgraduate teaching program, which we have named Kaksha. So, Kaksha is a novel postgraduate teaching program envisioned by Rajasthan Ophthalmological Society, which will cover all the major topics over a period of 2 years, covering all the current curriculum of postgraduate ophthalmology residency program in India. We'll bring the best of national and state faculty to share the knowledge and interact with all the residents and even practicing ophthalmologists also. So the residents are also encouraged to put forward their doubts whenever they can and freely interact with the speakers. Coming to this class, we have today Dr. Rupak Roy from Shankar Netralaya, Calcutta, to enlighten us about one of the most important diagnostic modality of our times, that is optical coherence tomography, OCT, which every ophthalmologist should know, irrespective of the subspecialty he or she is practicing. Dr. Rupak Roy is a senior VR consultant and deputy medical director in Shankar Netralaya, Kolkata, and he has more than 130 publications in PubMed Index journals, and is managing complex vitreoretinal disease and has a keen interest in retinal imaging also. In addition, he is a dear friend for many years, and I can tell you from my personal experience that he's one of the best minds in retinal imaging in the country. So let's utilize this great opportunity to interact and learn from him. I would now like to welcome our esteemed panel here, comprising of Dr. Khilani sir, President ROS. Sir, are you there?
Yes, I am here.
Good evening, sir. Good evening.
Good evening. Good evening.
Dr. Sanjeev Desai, sir, President-elect from Jodhpur. Dr. Virendra Agarwal, Vice President, Rajasthan Ophthalmological Society. Dr. Ghulam Ali, our Dynamic Secretary, Rajasthan Ophthalmological Society. Head of the departments of various colleges in Rajasthan and outside the state. And we have 4 residents, Shweta Akshika from Jodhpur and Yashasvi and Ayushi from Udaipur, third year PGs on the hot seat, so they can interact and Rupak can interact with them. I suppose, sir. So keep a strong vigil also, as there are 2 grand prizes at the end of the class to be won in every Kaksha. I now hand over the proceedings to the class to the Dynamic Secretary, Dr. Ghulam Ali. Sir.
Good evening, everyone. I welcome Dr. Rupak Roy and Khilani sir. Good evening.
Good evening. Good evening.
Yeah. So, Rupak, you can start the session now.
Yeah, is my slides visible?
Yes, yes.
Yeah, at the so am I audible and are my slides visible?
Yes, Rupak, you are audible.
Yes,
the
yes,
slides
yes,
are visible.
audible.
Thank you. Thank you very much. At the outset, I would really like to thank Kaksha and Rajasthan Ophthalmological Society for giving me this opportunity. I take this opportunity to say hello to all the seniors from Rajasthan who are in the panel. My respect to them, and all the people who have joined. The idea of this presentation is optical coherence tomography is a very important tool, a very important diagnostic tool in our day-to-day retina practice, and it has somehow transformed the management of retinal disorders. So there are many aspects to it. I'll be basically covering the basic aspects, what OCT is all about from a technical point of view, though we have to understand that we are not physicists, so I would not encourage the PGs to go too much into the physics part of it, because that probably is beyond our comprehension. But we should have some sort of working knowledge of how OCT works and what are the different types of OCTs that we have and what is the basis and how this technical information kind of transforms into the clinical images that we get and how we interpret those images. And then in the next part, I will be covering some basic retinal disorders, which again, we see in day-to-day retina practice. And it's very important for an exam point of view. See, OCT can always come as a long question, as a short question, as a short note, as a long question. And more importantly, in vivas and people who are appearing for the DNB exams, you are rest assured that at least 2 to 3 OCT images you are going to get in your OSCE. So OCT is something you cannot run away from. We all have to face it. It is very easy to understand. I thank finally, I really want to thank Vishal, Dr. Vishal Agarwal, who himself is a very renowned retinal surgeon and who is my close friend, for giving me this opportunity to speak in front of all of you. As Vishal said, we have a bunch of young guns with us. Shweta, Dr. Shweta, Dr. Akshika, Dr. Ayushi, and Dr. Yashashvi, who will be in the hot seat and who really will be interacting with me, because practically it is not possible to interact with a large group of people. So maybe we'll keep on interacting with a small group, and whatever doubts or questions that crop up in your mind, you can straight away shoot it in the chat box. So without much ado, let us start with so what is basically OCT? It's basically a high resolution cross-sectional imaging of the retina. It basically measures the echo time delay difference between the reflected lights. There are 2 lights that are going inside the eye that I will come up again. And it is somewhat analogous to ultrasound, which basically use the ultrasonic rays. And the most important part is non-contact. So before I really go into the details of OCT and rest of it, Dr. Shweta is here. Can you just tell me, Shweta, what are the various retinal imaging modalities that we have, the basic retinal imaging modalities that we have in our clinical practice? Can you just enumerate them, like 1, 2, 3, 4?
Yes, sir. There is direct ophthalmoscopy, indirect ophthalmoscopy, and OCT and fundus camera. And
Very good. Excellent, excellent. Akshita, would you like to add anything to this, what she has said?
Rupak, can you make the screen a full screen of a slideshow?
Oh, it's not full screen, huh? Okay, just give me 1 second. Yeah, is it now full screen?
Yes.
Yeah. So yeah, so as Shweta has told us, direct and indirect. Then she talked about color fundus, and then FFA. In any other investigative modalities, Dr. Akshika, can you tell us apart from what Shweta has told us?
So fundus angiography.
Excellent, excellent. So fundus angiography is very good. And
So
anything else?
Slit lamp with 90D lens.
Yes, excellent. So we have great answers here. So what we have to understand is, whenever we look at any imaging modality, no imaging modality is actually standalone. They all complement our clinical examination. So the clinical examination is must. You should never come to a diagnosis just by seeing the OCT report, ultrasound report, or that, for example, FFA report. So as Shweta told us, that direct, indirect examination with 78 diopter and 90 diopter, these are essential tools. We have to see the patient with these tools. These are clinical methods. Then we decide which modality is useful for which disease. So we have to understand one very basic thing. OCT is possible only when the media is clear. The best results of OCT are obtained when the media is clear. That is, you have a clear lens, clear cornea, the vitreous is almost clear. Then only we get a good OCT image. If you have a dense cataract, if you have a corneal haze, you will not be able to get a good OCT image. So before you order an OCT, you have to understand the prerequisite for a good OCT imaging. The prerequisite would be that it has to be a clear media. Yes, obviously, if there is a dense cataract, little corneal hairs, we still can get some good OCT images, but most of the times it is done mostly in a clear media. And before we go into the OCT part, another thing that we have to understand that different imaging modalities that we have has different roles in our clinical practice. Say, for example, ultrasonography for retinal disorders is mostly done when the media is hazy. That is, you have a dense cataract, you are not able to see the retina. Then, of course, you are not going to do OCT, you are going to do ultrasonography. You have a vitreous hemorrhage, where due to hemorrhage, the light is not able to reach the retina. So if the light is not able to reach the retina, you are obviously not going to see the retina. So in those cases, you do ultrasonography. There are indications of doing ultrasonography in clear media also. Say, for example, if you're looking for an ocular tumor, but that probably is a separate issue and a separate class. Coming to the next imaging modality like fundus fluorescein angiography, which actually gives us information about the vascularity or the vascular abnormalities within the fundus. Similarly, we have another imaging modality, which is the ICG or the indocyanine angiography, which gives us details about the choroid. But these are all vascular. But this FFA, this ICG, all basically are invasive methods because you have to inject a dye. You have to inject a dye. So that obviously is a deterrent, because if the patient has a kidney problem, in the case of a fundus fluorescein angiography, you cannot do the FFA. If the patient has a liver problem, you will not be able to do the ICG. And again, the patient has to be injected a dye, patient is fasting, and there are a lot of things. So in comes OCT. OCT is a revolutionary device because it can help you see the retina, see the details of the retina. It does not need injection of any dye. And the most important thing is it is non-contact. That is, you are not touching the patient. People who have OCT in their clinics, in their institutes will know, but who probably do not have access to OCT. So it is a non-contact. That is, there is no contact with the patient. So going back to the presentation, so now we have sort of discussed what are the basic imaging modalities that as a retina practitioner we have. First, we have a clinical examination that can be done with a 78D, can be done with a 90D, which is known as the slit lamp biomicroscopy, can be done with the indirect ophthalmoscopy, IDO. Then we have the imaging modalities, ultrasonography, which is mostly done in case of a opaque media, where there is a dense cataract, there is a vitreous hemorrhage. We have FFA and ICG, which are excellent tools, but they are invasive. They need dye needs to be injected. They give information of about the vascular abnormalities. And also we have something known as the color fundus photography, which we use to document the fundus, whatever we see. If you want to take a picture, document. Of late, we have some fundus imaging methods known as the Optos, which is a wide angle fundus camera where you can actually see to the extreme periphery of the retina, almost post equator, to see any peripheral holes, lattices. So these are the various imaging modalities, and the most commonly imaging modality that is used in our day-to-day practice is OCT. OCT is a high resolution cross-sectional images of the retina. It is non-contact. So why OCT? So optical. So OCT, if you break the OCT into three parts, it is optical, coherence, tomography. So what is optical? Because it involves imaging, the imaging involves light rays. So optical, the term comes. Then you have coherence. As I told you, it involves two light waves with constant phase difference. So this is the physics part of it. And tomography means you are actually sectioning the retina. You are actually sectioning the whole retina and seeing the single individual section. You can obviously go up and down to see all the sections of the retina, but when you get so when we typically see a OCT scan, we see basically one section. So optical coherence tomography, optical means imaging involving the light, coherence means two light waves with constant phase difference, and tomography means section. This is a Greek term, so this is an important terminology that we have to understand. So this is the first image of the OCT, which was published in the Journal of Science, which is a very prestigious journal. So it was by this Fujimoto and Pulfito group, and this is the first image of the OCT that we have got. So this was probably the starting point, and then this field just exploded. This field just exploded. So if you look at the timeline of OCT, if you see around 1971, we have the concept of seeing inside the tissue. Then around 91, we saw the first OCT image, which I just shared, but that was in vitro. Then 93, we come in vivo. Around 96, we had the first commercial OCT device, which was a primitive OCT device. Then obviously there was very rapid development of OCT devices, and now we have second generations, third generation is straters, then we have spectral domain, then we have something known as a swept source, and then finally what we have now, something we call OCT angiography. Of course, OCT angiography is beyond the scope of this class, but we might discuss it in a passing bit in some of the slides. So the basic development of OCT started around 93, and now we have OCT angiography, which is the latest part. Talking about the physics part, we have talked about interferometry. So what is basically interferometry? Interferometry basically measures the difference between reflected light waves from a tissue of interest, say for example retina in our case, and that from a reference path using a low coherence light. So the light reflected from the retinal structures interferes with the reference beam light, and the interference of echoes is detected, creating a measurement of light echoes versus depth. So this is the basic gross principle of OCT. If you want, you can take a snapshot of this slide, which can act as a sort of a starting point of any OCT short note that you're going to write. So whenever you talk of OCT, we talk of axial resolution, and we talk of the transverse or the side-by-side resolution, and we talk about the penetration depth. That is how deep the OCT goes, starting from the retina, whether it goes up to the sclera, up to the choroid, so how deep it goes. So axial resolution is determined by the bandwidth of the light source and the coherence grading. Transverse resolution is limited by the confocal gating or the size of the light spot that can be focused on the retina. And penetration depth determined by the scattering coefficient of the tissue. These are all physics terms. We should not go too much. What we need to know is resolution, that is transverse, that is side by side, and axial. These are two important terms we need to know, and we need to know how they change over a period of time across the systems. And penetration depth is very important because as the OCT technology has advanced, more and more penetration of the rays are possible. So in a way, the earlier generation OCTs, we had information only from the retina. But now the latest generation OCTs, we are able to see up to the sclera, almost up to the sclera. So that is what this penetration depth means and how they differ. So if you see the first available OCT instrument, the OCT1, which we call it, had a resolution of about 18 microns. So briefly, what is the principle of low coherence interferometry? So if you have a high resolution system and you have a broad bandwidth and there is a low coherence length light, so there is a low coherence light source which goes through a beam splitter which is provided in the machine, and it breaks into two. It goes into a reference mirror and a scanning mirror, and again comes out from the eye, and then you get an image. So what are the basic types of OCT that we have? So the basic types of OCT are the time domain OCT and the spectral domain OCT and a swept source OCT. Shweta, Anshika, Yashashvi, can you tell me any names of any OCT machines that you're aware of?
RTView,
RTView is a fantastic. RTView is a OCT machine. Yes.
Topcon,
Topcon. Yes.
Heidelberg,
Heidelberg. Yes. Yes.
Spectralis.
Heidelberg Spectralis. Yes. Yes. Yes.
Yes.
So there are various type of OCT machines that are available in the market. So the first thing tomorrow that the PGs and the fellows who are attending and who don't know all types of OCT machines, the first thing that you should do is go to the OCT room tomorrow and try to see what machine you have. If you don't have a OCT system in your institution, but you see a lot of patients who come from outside with a OCT printout, always in the top of the OCT printout, the name of the machine should be there. So it's a good idea to know what machine is it. Then you can understand what type of OCT scan you are looking into. So basically, we have a time domain system, which earlier we used to use. We had machines like Stratus, which is obsolete now mostly, but there are some places which are still using Stratus, and it gives us limited information. So time domain OCT measures each point on the retina in a sequence over time. That's why it's called a time domain OCT. Then we have a spectral domain OCT, which employs a spectrometer to measure the interference. And then we have something known as the swept source OCT. So from a student's point of view, this could be part of a short note. What are the types of OCT? Then yes, these are the 3 types of OCT. When you are donning the hat of a clinician, you need to know which OCT machine we are using, because different OCT machines can give slightly different kinds of information. So it's a good idea to know OCT printout is from which machine, and if you have OCT in your institution, which OCT is it? So this is what OCT image will look like. This is what we call as a B scan. Here you can see a section of the retina. So how this image is obtained? This image is obtained by passing multiple light sources, which are known as A scans. So these multiple light sources are falling on the retina, and the machine extracts information from them to provide a composite B scan image. So OCT, many one-dimensional scans, which we call A scans, are performed at several depths to create a 2-dimensional image, which is we call B scan. Those B scans, if acquired closely and rapidly, can be translated into volumetric image, which is known as the C scan of a retina. So this is the A, B, and C scan of a OCT image. So if you look at the working of a time domain OCT, it's again the principle of low coherence interferometry, and if you have a reference mirror and a transverse scanning mirror, and the main thing here, the reference mirror is moving. So this is the key point. Whenever you are asked to differentiate between the workings of an OCT machine, so all the OCT machines work on the basis of interferometry, but the individual OCT systems have slightly differences in their physics. So time domain OCT, the reference mirrors is moving. On the contrary, if you go for spectral domain OCT, the same thing happens. Yeah, but the reference mirror is stationary. So the time domain, the reference mirror is moving. In the spectral domain, the reference mirror is stationary, and it goes through a spectrometer to give you a OCT image. So what are the basic differences? So the main difference comes in resolution. So that is the ability to see small lesions. So resolution of a time domain OCT is around 10 micron, and the spectral domain is around 5 to 6 micron. So this is again a very important slide from a short note point of view, where you are asked to differentiate between the various generations of OCT briefly. The speed of acquisition of the time domain is slow. The spectral domain is very fast, around 52,000 A scans per second it takes. There are a lot of artifacts that can happen over time domain OCT. Spectral domain OCT has some sort of artifacts, but they're very less. It gives you only a 2D view, but the spectral domain OCT, you can do a 3D reconstruction also. So commercially available is Stratus, and commercially available spectral domain is Topcon 3D, Cirrus from Zeiss, and Spectralis from Heidelberg. So the next modification in the OCT systems came in the form of Spectralis, which is CSLO based or confocal scanning. So confocal scanning is again a technology where where laser light allows you to focus precisely on points on the retina, confocal points, and it is least interfered by media opacities. And another good thing about the Spectralis system is you can get good OCT images even with a small pupil size. So this is the comparison of various SD OCT machines that are available. So you can see they're mostly same, all have axial resolution around 5 to 7 microns. They probably differ in their scanning speeds. Now coming to swept source OCT, which is the latest form of the OCT that we have. So just briefly, I want to touch upon one thing. There is on this terminology that has gained acceptance now. Before we have OCTs, so we used to call time domain OCT, spectral SD OCT or SS OCT. Now with the advent of OCT angiography, there is a lot of confusion sometimes can happen in the literature. So now the accepted terminology that has become is, if you are talking of OCT, you should write structural OCT. And if you're talking of OCT angiography, you can write OCT angiography. So if you want to write OCT, you tend to write structural OCT, which can tell us about time domain, spectral domain, or swept source OCT. So swept source is the latest form of OCT that we have. So SS OCT obtains time-coded information by sweeping a narrow bandwidth laser through a broad optical spectrum, and SS OCT detects backscattered intensity with a photodetector. So this is the working principle of a swept source OCT. So briefly, what are the comparisons? This is a slide that I've taken from an excellent IGO article by Dr. Muna Vendre from Shakanathala, Chennai. It's a review article. It's an excellent article. Do go through that article. It is very helpful. So we have 3 main types of OCT that we can talk of. One is a time domain, which is luminescent diode of 810 nanometers and axial resolution of around 10. Then we come to spectral domain, which uses around 840 nanometers and resolution around 5 to 7. And finally, we have a swept source tunable laser, which uses a 1050 nanometer light source. And see the scanning speed, it's humongous. It's around 1 lakh to 4 lakh A scans per second. So much superior to the SD OCT. It can let us see even up to the sclera. So this again is a very important table, which is must for all the PGs who are going for the exams. So we will come to the individual layers of the OCT, but briefly, this is how a time domain OCT looked into this slide. My mouse cursor is moving, and is it visible? Dr. Vishal, can you tell me?
Yes, it is visible.
Yeah. So this is a time domain OCT. You can see the retina here. This is the retina, but see, you are not able to appreciate the details. Now you are not really able to see anything. This is the RP, anything beyond the RP. Now here comes the spectral domain OCT. You can see how clearly the retinal structures are seen, but still the choroid is not so visible. And then we have, this is the swept source OCT, where you can see the retina nicely, and you can see way up to the sclera. This is the suprachoroidal canal. So this is in a nutshell that what we have talked about. This is the revolution of OCT that has happened, the advancement of OCT from just being able to see the retina to be able to see up to the sclera. This is a swept source OCT. So before we go into description of OCT, how different things look into OCT, I'll just like to clarify a few terms. One term is known as the ART, or the automatic retinal tracking mode, is available in Spectralis and many other machines to ensure that all B scans required to cover the imaging area of interest required coherently despite any eye movement. So it is a very common thing that whenever you image a patient with the OCT, it's very difficult for the patient to keep looking at the targets. The patient will always keep on moving his eyes. So all these machines have automatic live tracking, some sort of system which will compensate for small errors in the movement, so that even if patient moves the eye a little bit, the same area will be scanned. So this is one terminology that I want you to understand. Another terminology that we want to understand is the signal strength. We will come, where will you get this signal strength? Various machines have, so this is the strength of the signal of the light that is going inside the retina. So always before you evaluate a OCT scan, you should see the signal strength. So if it is a very poor signal strength, you know either the OCT is not correct, the patient was not correctly fixing, or there was a problem in the media like corneal haze, some cataract, or some vitreous haze. So a signal strength around 6 is desirable for Cirrus, around 8 for Zeiss Cirrus 6000, and for Spectralis it should be around 20 to get an optimal scan. And there is something known as the averaging that you hear lot in OCT terminologies. So it's a basically not unique to OCT, any imaging system. So it's a commonly employed technique where multiple images of the same area are taken and processed to get a better quality image. So it's basically a photographic terminology, which, because OCT at the end of the day is a digital photograph, so this is very much used in OCT terminologies.
Rupak, I'll just like to interrupt you for a second.
Yeah.
So all the residents are requested, if there are any doubts from the class or any slide, you can just type your question or doubt in the chat box, and we'll be happy to answer them after the class. Okay. So the chat box is open for any questions or any queries by the residents. Okay, you can continue.
So now I will come to normal OCT. How does a normal OCT looks? So this is an image from a spectral domain OCT. So the moment you see a OCT scan like this, so if you are practicing retina for 10 years, it will not pose you a challenge. But for people who are joining maybe first year, second year, sometimes OCT, you can have a wide array of information and you can tend to get lost. So what we have to do is we have to approach a OCT scan with a very structured way. Then only we'll be able to understand. So this is the fovea. So this is very easy. This is very a starting point. This is the fovea. This is the umbo. You can see a hyperreflective dots, not always seen, but sometimes in very young patients, if you do OCT, you can see a hyperreflective dot at the center, which is the umbo. So OCT is a unique imaging modality because it almost correlates to histology of retina. That means if you take a sample of the retina, do histology, you will see the layers, and you do OCT and you see all the layers. So OCT is probably a only imaging modality in ophthalmology which gives you a almost near histological correlation. So this is the vitreous, which is normally anechoic, which is normally black. Then this is the choroid, which is below. This is the RP, which is below the RP. And this is the neurosensory retina. So basically, whenever you see a OCT, you have to look at the vitreous, you have to look at the fovea, you have to look at the neurosensory retina, you have to look at the choroid. So these are the 4 parts that you basically should be looking whenever you get a printout of OCT in your hand. So now, one thing before we move to the next slide. So OCT printouts can come in various ways. You can have color printouts or you can have black and white printouts. So if you have an option, I would say always go for a black and white printout, because the black and white or the grayscale printout, the contrast is much better. You'll be able to appreciate the details very much. Color printout, the advantage is you can have sort of color coding, like it is bright red, bright blue, but sometimes the color coding can be misleading. So this is OCT. So now let us look at the individual layers. So starting from inside, going towards outside, we have hyperreflective structure. This is the interlimiting membrane. Then we have the retinal nerve fiber layer. Then you can see there are two hyporeflective layers. Hypo means they are black. So this is a large hyporeflective layer, and this is a smaller hyporeflective layer. This is the outer nuclear layer, and this is the inner nuclear layer. So there are two hyporeflective layers. One is the outer nuclear and one is the inner nuclear. Then you have two hyperreflective layers. One is the OPL, or the outer plexiform layer, and then you have the IPL, which is the inner plexiform layer. So these four layers are easy to identify and should ideally be picked up. So examiner can sometimes ask you questions, why is the ONL hyporeflective and not hyperreflective? So it basically depends because the arrangement of the nucleus in those layers. So they are arranged vertically in the nuclear layers. The nuclei are basically arranged vertically. So as they're arranged vertically, the light tends to pass through them and not get transmitted back. That's why we have a flow deficit or a hyporeflectivity. On the other hand, in the OPL and the IPL layers, the nucleus are basically transversely arranged. So that's why you have hyperreflective. Then you have the ganglion cell layer, which lies above the IPL layer. So whenever you see OCT, you first see the retina and you try to identify the two major hyporeflective layers. One is the ONL and one is the INL. And then you come to the outer part of the retina, or the outer retinal structures. So here it is important to understand that the outer retinal structures, you have basically four white lines. 1, 2, 3, 4. So there are four white lines. The innermost white line is the external limiting membrane. This is the ELM. This is the innermost white line. Then we have something previously we called ISOS junction. Now we call it the ellipsoid zone. So this is the second white line. Then we have another white line, the fourth white line, which is the RP Brooks complex, which is the RPE. And we have choriocapillaries. I'm still left with one white line. This is this white line. I'll come to it. And finally, in the choroid, we have the choriocapillaries. So if we magnify this image, you can see there is this third white line, which is previously we used to call it OS steps. Now we call it the interdigitation zone. So this terminology is very important. We have to learn it. We have to learn it. So every time you see a OCT, you see the neurosensory retina, you try to see these four white lines, and then you try to see the choroid. So this is how you can break a OCT printout or an OCT image into. So again and again and again, these four white lines are very important. One is the ELM, which is the inner. Then you have the ISOS or the ellipsoid zone. Then we have the OS steps or the interdigitation zone. And you have the RP Brooks, and then you have the choriocapillaries. Now, this is an image from a DRI OCT Atlantis, which is a swept source OCT. You can actually see the scleral surface. So this is the beauty of a swept source OCT. So this is the neurosensory retina, this is the choroid, and this is the scleral surface. So now I think now you are able to understand what this OCT generations are and how they have translated into clinical practice. So as the OCTs have got more and more advanced, the resolution of the OCT is crisper, clearer, and we are able to see much deeper to almost to the sclera. So this is what OCT transformation has really shown. Now, this is an image which is very easily available. This is an article from Ophthalmology, which is a journal of the American Academy of Ophthalmologists. So this is a group of very eminent retina specialists who have got together, and they have proposed anatomical classification or anatomical naming of the OCT layers. So if you see, we have actually covered all this. So this is the neurosensory retina and this is the outer retina. So again, there are four white lines. You have the external limiting membrane. Then you have if you see closely, just below the external limiting membrane, you have a black zone. Now that is known as the myoid zone. This is a layer of the photoreceptor. So this is the myoid zone. And then you have another white line. This is the ellipsoid zone that I've discussed just now. So we start with ELM, which is hyperreflective. Then we have myoid zone, which is hyporeflective, this small slit like black thing. Then we have ellipsoid zone. Then again, we have a small black area here. So this is outer segment of photoreceptors, number 12. Then we again have a white line, which is the interdigitation zone. Finally, we have the RP and the Brooks. So it will be a good idea. This article is actually freely downloadable. So it will be a good idea if all the PGs can download this article, just download this image and keep a sort of snapshot of this image in your computer, in your mobile. So because see, initially when you start with this OCT things, you will forget which layer is what. So the only way to learn is to read it again and again. So moment you see a OCT, open your mobile, open this picture, see the layers, and then see the OCT. So then if you do it, keep on doing it consistently over a period of time, you will know all the layers. And so whenever you see a OCT, you know at which layer the pathology is. So it is very important to know what are the normal layers of the retina that can be seen on OCT. And unless you see, you know which layer is what, you will not be able to understand which layer the pathology is. So this is a brief list of the layers. Again, this is I have taken from that article. It is easily available. We have already discussed. I'll not go into details. Now this is a close-up of the choroid. So I'll just so choroid, as you know, are basically have three vascular layers. One is the choriocapillaries, one is the satellars, which is the medium vascular layer, and one is the halars. So if you see, this is the settlers layer, this is the halars layer or the large vessels, and this is the chlorioschedal junction. So, and in Schweppes OCT, you are actually able to see the suprachoroidal space. This is the suprachoroidal space. So now we have done with the basic OCT. How does a basic OCT look like? Dr. Yashashri, can you just tell me briefly? Did you understand the 4 white lines that I was discussing about in the outer retina? Is it clear to you?
Yes, sir. Yes, sir.
So you were able to see all the 4 layers?
Yes, sir. I was able to see.
Good. So now coming to OCT scan protocols. So what does that mean? That means whenever you open a OCT machines, the machine will show you this screen. So this screen means that you can take a scan like a line scan, just a single line scan. You can take a raster scan where there are lines like this. You can take a radial scan where there are crisscross lines. So we will just briefly go what are the various scans and in which case you should do them. So this is a snapshot from a Zeiss system, a Cirrus system. So this is a radial scan. So this is a macular cube or a 3D scan, and this is a raster scan. So you have to know which scan is what. And now if you want to know, so a line scan, it obtains a linear scan over length of 5 mm by default. So although the length and the angle can be varied, so it is a single scan of a single area. Now we come to the next, which is the radial scan, where you have a crisscross line like this, which can scan 360 degree of the fovea. So 6 to 24 equally spaced line scans, useful for retinal thickness and volume analysis. So this is important. Whenever you want to go for a retinal thickness, this scan is important. Then we have a raster scan, where this is the raster scan. We have a sequential lines. And then we have the repeat scan, where you can repeat all the previously done scans. So what and how to look into a OCT report. So this is now, it gets interesting. Now you have a OCT printout. There is a lot of information that is happening in the OCT. how to make sense of it. So this is a typical OCT printout from my hospital. So if I look closely, so you have basically a patient identification. This is the patient ID number. You have the date of the birth of the patient, which is important because retinal thickness we know can vary with the age. So there is a reference standard. So as I was telling you, you can always know which company it is. So it's a Heidelberg. So it is a Spectralis. You have the gender of the patient. The patient is a male patient. Now, this is OD, that is the right eye, and this is OS, which is the left eye. Now, this basically is the OCT scan. So this is the OCT. Now we also have these two circles here. So what do they mean? So this is a thickness circle. So this is basically known as the ETDRS grid. ETDRS is the ETDRS study, which we all should know, which was a diabetic retinopathy study. So there they created this circle, which is centered on the fovea, and they had measured certain parameters in the ETDRS study. Now this OCT scan, this circle is centered on the fovea, and it gives the thickness of the retina from the center to the periphery up to this 6 millimeter. So this is 1, 3, 6 millimeter. There are 3 circles. The circle diameters are 1, 3, and 6. So this is the 1 millimeter circle, the center. So the thickness within the 1 millimeter is 272. That is the retinal thickness, which is measured from the ILM to the RPE. Then we have the second circle, which is 3 millimeter. There the thickness is 294. And then we have the 6 millimeter circle where both sides we have 291 and 270. And it also gives you a volumetric analysis. So this is one. So this is the OCT scan. This is the ETDRS grid, which is actually superimposed on the OCT, and they have measured the thickness. And then you have something here. It is a black box-like thing. So this is, if you see closely, so this is the infrared image of the retina. And if you see this green line here, so you know the scan of the OCT has gone through this line. So the image of the OCT that I am getting is through this line. And you have something here which is written 10 out of 19. So here it is the signal strength. So if it goes down, the image quality goes down. So here it is 9 out of 19, and you see there is a lot of haze. So this is because of the cataract. So I'll go to the next slide. So so this again is just summarizing these points. This is the ETDRS grid, which gives thickness. This is the infrared picture of the retina of the eye that we are taking. So if I magnify one part of the OCT, I'm extremely sorry. I have done an oversight. So whenever we project any image of any patient in any presentation, we should actually ideally cut out the name. So I'm really sorry about this. This should not go out as a wrong message. This is my honest mistake. So this is the magnified screenshot of the ETDRS circle. So you can see again, three circle, 1, 3, 6, and this. So this is the 15 out of 31. You can see it is here. It is the signal strength. That is, what is the strength of the signal? As we have discussed earlier in Spectralis, if the signal strength is more than 20, it is good. So always you see the signal strength to know the quality of the imaging. Now, interestingly, the OCT machines, in the previous image, we had infrared image, but we can actually have a FFA image also side by side. So this is a FA image, which can be superimposed on the OCT on the right side. But always, whenever you see a OCT image, you should see the corresponding retina from where the OCT is going through. But in some machines, they have the capability of superimposing it on a FA image. So you can basically see focal CSR leakage, and then you see where the OCT is going, where the fluid is there. So here it is written FA, that means it's a fluorescein angiography image. Yeah, so this is how if you break it, this is ART, which is the tracking of that means the tracking option of the machine is on. And this is the FA timing when the FA was taken. So these are all the parameters that you can see. So now we can have an infrared image that I had discussed earlier. You can see things written like OCT 30° and 9.7 millimeter. That means the length of the scan is 9.7 millimeter. This whole scan is 9.7. And 30° is the degree that they have measured. So these are the various meanings of OCT. You can superimpose to a blue reflectance image and to a multicolor. So there are various types of images that you can superimpose your OCT on. So your right side image is basically the OCT, and the left eye should be some sort of fundus imaging. Either it should be a color fundus photo, it could be a fundus fluorescein, it could be infrared. So whatever it is there, it should be written there. Another very important thing is to understand that whenever you see a OCT scan, you should see from where the OCT has passed. So this is a patient of non-proliferative diabetic retinopathy. Now, if you see, this is the OCT of same patient. So the scan, this is the scan line. Here there is no edema. Here there is no edema. But here you can see there are these black spots which suggest edema. So whenever you see a OCT of a patient, you should see from where, through what point the scan has gone. Because now, for example, the OCT was done and the OCT technician or the optometrist has given you this part of the printout. So here the patient does not have any edema. But in actually, when the scan passes through the fovea, there is edema. So the alignment of the scan is very important. So whenever you see a OCT, you see what is the type of the OCT, you see what is the signal strength of the OCT, you see what is the thickness in the OCT, and also you see from through which point your scan line has gone. Always the OCT machines will show you the scan line. So they should go actually through the fovea when the fovea is the area of interest, or through the area of interest. So if you see a OCT scan like this, which based on this, you will not offer the patient in treatment, but actually the patient needs a treatment because he has edema. So always look for the scan line. There is sometimes in your OCT printouts you will see this written, which is EDI. EDI is nothing but enhanced depth OCT. So enhanced depth OCT is a kind of spectral domain OCT where you want to look into the choroid. So this is the choroid is nicely seen, and the EDI here means enhanced depth OCT. So again, IR is infrared. This is the infrared image. So that's why they have written IR. 30° because they are scanning 30° of the retina. ART they have written because the eye tracking is on. That button has been kept on. OCT plus, that means this is the IR image, then plus OCT also 30°. The scan is 8.7 millimeters. So this length of the scan, full length is 8.7 millimeter. Then they have again ART button on. Quality of the scan strength is good, is around 32. That's why the image is so clear. And you have EDI mode on. So EDI is a button in the OCT machine which you have to click. The moment you click EDI button, they will click the image of the choroid. And whenever you see the OCT printout and you see EDI written, that means this is a EDI mode. So another good idea is, so not always you have access to the machine, but if you have access to the machine, do try to look into the full video. So you can get actually full video of the OCT, and you should make it a habit to see the OCT video from top to down. So then only you will be able to see a lot of information. So always try to see the OCT video. Now, most OCT machines will give you retinal thickness by default. So there are algorithms within the machines which give you retinal thickness, but choroidal thickness, none of the commercially available machines will give you. So if you are doing a thesis on a choroidal thickness, if you are trying to see the choroid of a patient, you have to know how to measure the choroidal thickness. So it's very simple. You have to draw a line from the RPE to the scolioskeletal junction, and you can measure the choroidal thickness. I will share a very small video. This is from my clinic, where I am actually measuring the choroidal thickness. So you take a caliper, you go and you just start from the RP, you go to the chorioscleral junction. It's very easy. Every one of us can do it. You can do loads of thesis on choroidal thickness because this is a new thing. But you have to know how to measure the choroidal thickness. This is how to measure the choroidal thickness. None of the machines will give you automated choroidal thickness measure. Now we come to indications for OCT. Now, before I go, can I ask Ayushi? So Dr. Ayushi, can you just tell me which OCT machine would you want if you are looking for a choroidal pathology like VKH? Which OCT machine?
So
Excellent. So we will choose a swept source OCT because it focuses on the choroid.
Rupak, there is a question from one of the residents.
Yeah.
So what does number 11 signify written in the bracket of ART?
Yeah. So this is again a very interesting question. So ART actually tracks the minute movements that the eye has made. So it is the number of movements that they have corrected during this scan that is written. Any other question, Vishal?
No, you can proceed.
Yeah. So now we'll come to the indications for OCT. Briefly, they are macular edema, PD, central serous retinopathy, vitreomacular interface disorders, macular holes, and various other. I'll just briefly go through the basic pathologies. These are very basic images. So I think they will be helpful for all of you. So again, OCT, when you're trying to interpret, look at the vitreoretinal interface, look at the neurosensory retina, look at the outer retina, the 4 white lines, look at the choroid. So always see the OCT in a structured fashion. Don't start from choroid, don't start from the middle. Always start from the vitreoretinal interface. Then see the inner retina. Then see the 4 white lines. Very important 4 white lines. Then you see the choroid if it's a swept source or a spectral dome. So this is a image of a posterior vitreous detachment. So you can see this is the retina. So here this is the posterior vitreous, which is nicely attaching. But here you see this layer is completely separate. So here you have an incomplete PVD and here you have a complete PVD. So OCT is a wonderful tool. Complete PVD can only be seen clinically as can any of the person on the hot seat tell me, Shweta, Akshika, clinically, how can I tell there is a complete PVD? What is the clinical sign for it?
So there will be a V's ring.
V's ring. Brilliant. Yes, absolutely nice. So if you see a V's ring clinically in indirect ophthalmoscopy, you know there is a complete PVD. Now, so this was almost a normal looking vitreoretinal interface. Vitreoretinal interface means the interface between this is the retina and this is the vitreous. So this junction is the vitreoretinal interface. So here it is, you see this is anomalous. So this is the posterior hyaloid that is in the vitreous and this is pulling the retina. So you have a vitreomacular traction. So this is a VMT. Sometimes you can see this hyperreflective lines above the vitreoretinal interface. So those are nothing but epiretinal membranes. So the epiretinal membranes are hyperreflective lines. So they can be globally adherent or they can be focally detached. That means there can be small space or there can be this. So sometimes this can be used for surgical decision making. You have focally detached, you know, the surgical dissection here will be easy. On the other hand, if it's globally adherent, it might be a little difficult. So sometimes you can have small strides of the ILM in cases of epiretinal membranes. So again, this will show you various types of vitreomacular traction that you can have. You can have a VMT, very early VMT. Then as the traction progresses, you can see a small cystic spaces. Now understanding these changes are important because unless you remove this membrane, you remove this traction, this cystic spaces will not go. So these are the patients which are candidates for surgery. So OCT is very helpful in decision making. So now you see this patient's vitreomacular traction is so much, the retina is stented, there is fluid here, there is fluid here. So this is a progressive disease. So vitreomacular traction is a very important finding in a OCT. Now we come to neurosensory retina. So neurosensory retina, you can basically have two types of lesions. One is hypo, or which is optically empty, or we can have hyperreflective, which are causing shadowing. So it can be edema, it can be subretinal fluid, it can be schisis, or it can be a gap in the form of a macular hole. Hyperreflective can be hard exudate, subretinal precipitates, hemorrhage, or corneal spots. So this is how a normal macula looks, and this is a large hyporeflective space or a cyst. So this is a hyporeflective round space. This is nothing but a cystoid macular edema. So this is a very common finding in diabetes, in BRVOs, and CRVOs. So we should look at the layer. So here you should see this is located inside the retina. Now here you can see in both these OCTs, the retina is thickened. Here there is a black spot here. Here there is a black spot here. So here you have to basically look for the ISOS junction or the ellipsoid zone. So this is the ellipsoid zone here, and this is the retina here. So this is a diffuse retinal thickening or a retinal edema. But here the ellipsoid zone is lifted. So this is a subretinal fluid. So this can sometimes be confusing. Okay, which is the edema, which is a subretinal fluid. So if you are able to see the ellipsoid zone or this hyperreflective layer and see its position. So if the black area or the hyporeflective area is above this ellipsoid zone, that means whatever is happening inside the retina, it's a diffuse retinal thickening. And if the hyporeflective space is beneath the ISOS or the ellipsoid zone, it's a subretinal fluid. So it is very important to differentiate, because subretinal fluid, there are many causes like CSR, hypertensive retinopathy. So, and diffuse retinal thickening is again a signs of vascular disease like BRV or diabetes, all those things. So coming to another important entity. So this, sometimes you see OCT like this, where there are a lot of hyporeflective spaces which are separated by straight white lines. So these are known as schisis. This is known as schisis or a schitic retina, which is a sign of chronicity. So now we have an image of an infrared image. Can any of the bright PGs from the hot seat just describe the OCT, starting from vitreoretinal interface to it, retina to choroid? Maybe Shweta?
Sir, there is cystic fluid in neurosensory retina. And
Yeah. So excellent answer by Shweta. But what I would suggest is, whenever you see a OCT, you first describe the vitreomacular interface. So the ventromacular interface is within normal limits, isn't it? Then you describe about the foveal contour. The foveal contour is elevated and distorted. Then you tell the retinal thickening. The retina is thickened. You can see the retina is thickened. Then you tell there is lot of hyporeflective spaces within the neurosensory retina, suggestive of cystoid macular edema. And then you see there is shadowing here. These are all shadows, because you, so always, as I told you, always describe a OCT in view of the clinical finding. So here there are a lot of hemorrhages which are causing this shadow. So always first describe the vitreoretinal interface, describe the foveal contour, whether it is maintained or distorted. Then comment about the retinal thickening. The retina is thickened. Then you tell where the hyporeflective spaces are, and then you can tell about the outer lines, which is you are not able to see because of a lot of shadow. Now coming to macular holes, you can have a lamellar or a full thickness macular hole. So this is a full thickness macular hole because there is no retinal tissue here. On the other hand, this is a lamellar macular hole. There is a gap, but there is a tissue here. So there is a partial tissue loss. There is a full tissue loss. Important because macular hole needs surgical intervention. Lamellar macular hole surgeries can be done, but most of the times we tend to observe them. So this is how progression of macular hole occurs. You can see all the stages of the macular holes. Now coming to hyperreflective lesions. So you can see there are hyperreflective lesions which are causing shadowing, So these are mainly hard exudates which are found in the outer plexiform layer. Also, they can be found in the subretinal space in case of CSR. Now, another set of diseases which cause shadowing are the hemorrhages. So if you have retinal hemorrhages, so these are all shadowing. You're not able to see any part of the choroid. You're not able to see any part of the retina here. So this is a subhyaloid hemorrhage. This is a sub-ILM hemorrhage. This is sub-ILM. You are not able to see the retina. And finally, this is a subretinal hemorrhage. You are not able to see the choroid. So that means wherever, at whichever layer the hemorrhage is there will be shadowing, and the immediate next layers you will not be able to see. Coming to RP, you can have a lot of abnormalities like RP atrophy, pigment epithelial detachment, drusen's, and choroidal, or which now we call as macular neovascular. So now this is RP atrophy, which is, this is a, you are seeing a lot of hyperreflectivity here. This is known as back scattering. There are two types of OCT terminologies that we have to know. One is the back shadowing, which is shadowing due to hard exudates, hemorrhages. And second is back scattering, where there is so much of thinning of the RP that the light is getting transmitted in abundance and you're getting a shadow. So this is known as back scattering, which happens in RP atrophy. Increased reflectivity of the choriocapillaries, loss of overlying photoreceptors. Another important thing is the pigment epithelial detachment, which is the elevation of the RPE. Here we have to see, this is the RPE, which is elevated, and you have to see the Brooks membrane. Based on the presence or absence of this layer, you will classify it into various types of PD. So if you see a lesion like this, you see this is the RP, which is nicely elevated. You can see this is optically empty, and you can see the Brooks membrane very nicely. So this is a serous pigment epithelial detachment. On the other hand, you see the RP is raised here, but you are not able to see the Brooks. That means there is shadowing. So this is a hemorrhagic PD, where due to hemorrhage has cast a shadow, you are not able to see the Brooks. So based on Brooks, you are able to differentiate between a serous and a hemorrhagic PD. Also, sometimes you have something known as the fibrovascular PD, where you can see shadowing and there is a fibrous component here. So whenever you see a fibrovascular PD, it actually means you are seeing a choroidal neovascular membrane. So what kind of PD is this? Dr. Vishashvi, can you tell me?
Yes, sir. This is a serous PED.
Excellent. And why do you call it a serous PD?
Sir, because we can visualize the Brooks membrane clearly and there is no shadowing.
Yes. So this layer is the key. The moment you see this layer, you know it's a serous PD. Also, you can see drusen's, which are bumpy things of the RPE. CNVM can be seen very nicely. You can judge the activity of CNVM by presence of the subretinal fluid. And also there are various types of CNVM that can be seen on the OCT. So for example, this is, so always whenever you try to see a CNVM, you try to see whether it's a type 1 CNVM or a type 2 CNVM. Type 2 means it is above the RP, type 1 means it is below the RP. So whenever you are suspecting a CNVM, you try to see the RP. So here, whatever lesion is there is below the RP. So this is the RP, which is elevated, and there is the CNVM. So this is a type 1 CNVM. On the other hand, if you see this patient, you can trace the RP, and that hyperreflective thing is basically above the RP. So CNVM is basically a hyperreflective structure. So whenever you see a hyperreflective structure above the RP, you know it's a type 2 CNVM. Below the RP, it's a type 1 CNVM. So always see the RP, then see the lesion. And if you see this hyperreflective spot, this is a CME and this is a subretinal fluid, you know this CNVM is active.
Rupak, there is a question.
Yeah.
How do we differentiate between subretinal hemorrhage and hemorrhagic PED on the OCT?
Yeah, so that is a very excellent question. I will like to answer that. So if you see, this is, if I go back to my previous images, I think I had an image of a subretinal hemorrhage. Yeah, so this is a subretinal hemorrhage, and you are not able to see, this is the RP you're able to trace here. But here the RP, the retinal pigment epithelium, becomes untraceable. So here everything is obscured by the hemorrhage. But in a hemorrhagic PED, you'll be able to see the RP. So here you are able to see, yeah, again, this is a hemorrhagic PED. You are able to see the RP, and you know everything is happening below the RP. So this is how you can differentiate between a subretinal hemorrhage only and a hemorrhagic PED. So subretinal hemorrhage is hemorrhage below the retina, but the RP is actually back. But here the RP is elevated. So elevation of RP is the key. I think I've answered the question, Vishal.
Yes.
Yeah. So I'm going back to where I left. So this is another case where you can see fluid in multiple compartments. This is the CME. This is the neurosensory fluid. This is the ellipsoid zone, which is elevated. As I told you, anything below the ellipsoid zone, if it is black, it's neurosensory detachment or a subretinal fluid. And above means a CME. So this is how you can see various components of a diabetic macular edema. This is again a classical picture of a central serous retinopathy. You can see the ellipsoid zone is elevated and fluid. This is a SRF and this is the serous PED. Sometimes you can see hyperreflective structures, and they can be confused with CNVM. But in CSR, fibrin is very common. How do I differentiate it from CNVM? In CNVM, by definition, the RP should be breached. But here you can see, you can trace the intact RP. So always look for the integrity of the RP, then make a diagnosis. So Ayushi, can you tell me what is this? Can you describe the OCT just?
So this OCT shows normal vitromacular interface.
Excellent.
And altered
present.
foveal contour with retinal thickening and like hyperreflective space just above the Bruch's membrane.
Sorry, I didn't get you.
There is hyperreflective space in above RP.
Yeah. So very good. So this is a OCT where the vitromacular interface is correct, the foveal contour is distorted, the retina is thickened. This is the ellipsoid zone, and this is the RPE. There is a hyporeflective space. It is not a hemorrhage, because had it been a hemorrhage, the RP would not have been seen because of the shadowing. So it is a clear fluid. So mostly it's a neurosensory detachment. So it's mostly is a case of CSR. So excellent answer, Ayushi. So quiz, this is a difficult question. So what is this? I can, anybody from the attendees can also answer this. So, so any guesses? People on the hot seat? This is not a CSR. See here also the ellipsoid zone is elevated, the RP is intact. So this is basically something known as the Best disease. So this is not a very common condition. I found it interesting. That's why I put it. So here, this is elongation of the photoreceptors. This is a vitiliform lesion. So coming to retinal ischemia, so you can have a cottonwool spot. So whenever you have a retinal ischemia, there is hyperreflectivity of the retinal layers. So this is a cottonwool spot. See, the scan has gone to the cottonwool spot, and there is a elevation and retinal thickening, hyperreflectivity. This is a very interesting condition where there is a hyperreflectivity of just the middle part. So this kind of patients will present with a scotoma. So this is known as paracentral acute medullopathy, which is a kind of retinal ischemia. Coming to more common, you have a BRAO. You can see this is the BRAO. And you can see in this sector, there is a hyperreflectivity. Here, this part, which is normal retina, this retina is normal. But here, the reflectivity is more. So these are the clinical features of retinal ischemia. And finally, we have a CRAO, where you can see the whole inner retina is hyperreflective. So these are very classical clinical features, OCT features of CRAO. Coming to OCT in myopia. So myopia, there is a posterior bowing. So you can actually see the contour of the RP changing. And always remember, whenever you have a myopic patient, if possible, try to do a swept source OCT because that will give you more information. So this is a myopic CNVM. Again, you see this is the RPE and the thing is located above the RP. So it's a type 2 CNVM. And this is myopic retinal schisis. This is kind of schitic features that are very common in the myopia. There are various artifacts that you can see in OCT. I'll not go into details. I come to the end of my presentation. OCT is a very large topic. The time is very short. So I will come to the...
you are presenting a slide and is it a one word or it's an MCQ?
It's an MCQ.
So Rupak will give options and you have to type in the chat box and whoever types it first is the grand prize winner.
So this is a 50-year-old lady who comes to your OPD saying, "Doctor, I am having difficulty in vision." The patient is diabetic, but you are not able to see any hemorrhages, but you see OCT like this. And this is a very diagnostic OCT of a very common condition. So what is the condition? So your choices are lamellar macular hole. Just type the answer A, B, or C, or D. Don't write the full thing. Lamellar macular hole, micro hole, macular telangiectasia, or solar retinopathy. This is the OCT picture again. Vishal, you can tell when to stop.
You can stop.
Stop. So the answer is, anybody from the hot seat? This is a macular telangiectasia. So this is a very classic finding in OCT. So answer is C, macular telangiectasia.
Okay, we have got many responses and we'll compile and whoever has typed first will get the grand prize. Okay?
Yeah. So we come to the next and the last question of this grand quiz. So this is a young 8-year-old boy who comes to your OPD. The patient is hypermetropic and the patient has a vision around 6/18 and you see a OCT like this. So what is your diagnosis? So 8-year-old boy, hypermetropic, 6/18 vision and an OCT like this. So the choices are Stargardt disease, X-linked retinoschisis, Best disease, and retinitis pigmentosa. This is the image again. 8-year boy, hypermetropic, 6/18 vision.
Type your options A, B, C, D in the chat
A,
box.
B, C, D. So I'll tell the answer, Vishal.
Yeah.
Yeah. So the answer is X-linked retinoschisis. So again, the moment you see a OCT like this in a young boy, you know you have diagnosed a case of X-linked retinoschisis. You should congratulate yourself because this is a very typical finding. The moment you get a typical finding like this, you diagnose.
Most of them have got the correct answer. We'll just compile and let you know in the next class.
Thank you. So I come to the end of my presentation. Thank you very much for your kind attention. I might not have covered many topics, but most of the important parts I tried to cover. But as you know, OCT is a big topic. We can keep going on and on and on.
Excellent class, Rupak. Any comments from Dr. Ghulam Ali, Dr. Khilani sir, before we conclude today's session?
Dr. Rupak, thank you for the excellent presentation and thank you all participants for their time. Yeah.
Khilani sir is here. Any comments by him? Okay. So this has been a wonderful Kaksha on OCT with a full house, for more than 200 participants today. And thank you all residents, ROS executive, respected teachers, and Rupak for the excellent teaching. We look forward to the next class, which will be on corneal topography next week with more residents on the hot seat. Dr. Virendra is here. Any comments, Dr. Virendra? So you are muted. You can unmute yourself. Yeah.
It was an excellent talk, and particularly for the OCT, which is a very common day used tool for all practitioners, maybe doing only cataract or retina or any subject, because we see many patients of diabetes coming for cataract also. So pre-operatively, if you can do OCT in all cataract patients, I think it can save a lot of problems. I will share my personal experience. that initially I was not doing. So I had 2-3 patients who had a macular hole and it was not diagnosed in the cataract, and later on they created some problems. So I think
In
doing
a busy
OCT for
OPD,
all
you can
cataracts
miss
is a good
macular
thing.
findings, and especially if you're doing premium IOL, OCT is a must in all these cases.
Yeah.
Right?
And as he was saying, for the ISOS junction or the ellipsoid zone, that is very, very important for premium cases, because then the quality of vision and quantity both will be affected. And that can only be picked up by OCT, cannot be judged by any other examination.
R.K. Sharma, sir, good evening, sir. Dr. R.K. Sharma is the past president of ROS. Sir, any comments?
Good evening. Now, I also would like to join others in congratulating Dr. Rupak, and the class was very useful. Probably it was very useful for the residents, but it was useful for all of us, I would say.
Exactly.
Thank you.
Thank you, and keep giving your feedback and suggestions for the Kaksha experience to improve. And good night, everybody. Good night, teachers, the hot seat residents, and all the participants from Team ROS. Thank you so much. Thank you.
Thank you.